Hi, I'm Ivana Acevedo, reporting for Daily Bulletin. I'm talking with Dr. Wendie Berg, Distinguished Professor of Radiology and the Bernard F. Fisher Chair for Breast Cancer Clinical Science at the University of Pittsburgh School of Medicine and McGee Women's Hospital in Pennsylvania. She is sharing key learnings from her RSNA 2023 session, Screening Contrast-Enhanced Mammography as an Alternative to MRI. It's the SCEMAM study, yes? We pronounce it SCEMAM?
Correct, SCEMAM.
SCEMAM, okay. Thank you for joining me today, Dr. Berg. What are the benefits of contrast-enhanced mammography with digital breast tomosynthesis, and who are the patients that benefit the most?
So our study was focused on looking at women who qualify for an MRI, which in Pennsylvania there's a law requiring insurance to cover supplemental screening for women who have extremely dense breasts or heterogeneously dense breasts and another risk factor, lobular carcinoma in situ, prior atypical biopsy. These are a little broader categories than the original American Cancer Society criteria. And because of that, and we also knew from the Akron 6666 study and the DENSE trial in the Netherlands that about 40 to 42% of women who are offered an MRI won't do it because either of claustrophobia or inconvenience, a lot of factors. And so we felt like we needed an alternative to that. Contrast-enhanced mammography finds cancers in the same way as MRI because they show enhancement. They have abnormal blood vessels and more of them, and they're leaky. And so it, in many studies, has shown very similar performance to MRI. And we knew it was probably better tolerated based on some other studies. And in fact, our own survey of patients in several of our research studies, we found those who'd had both an MRI and a contrast mammogram for different reasons, over 70% preferred the contrast mammogram. Okay. In terms of who benefits, I mean, we have found a benefit in both the studies that we're doing, women who have personal history of breast cancer that we reported last year at RSNA, also the women who are at increased risk because of dense breasts, extremely dense breasts, lobular carcinoma in situ, were the most of the patients in the current study. We had 601 women who enrolled. They were aged 30 to 75. And we found 12 cancers, altogether, 12 women with cancer. And the women who had cancer, 5 of them, only 42% were seen on tomosynthesis alone. And there were another 6 women who were diagnosed with cancer because of the contrast mammogram. Importantly, the cancers that we found with the contrast mammogram were small. The median size was only 7 millimeters, and all of them were node negative. And so these are the right kinds of cancers that we want to be finding early. Interestingly, 3 of them were invasive lobular cancer, which is notoriously poorly seen on mammograms, even with tomosynthesis. And I think that may be a very encouraging result, especially for, I know the lobular breast cancer community is very actively interested in better ways to screen because many of them had delayed diagnosis. So I know that 3 of our cancers were actually among the only 20 women who had LCIS, and they're of course at more risk for having an invasive lobular cancer. So that may be a particular population that would benefit from CEM.
Thank you. In your study, what was the impact of contrast-enhanced mammography on cancer detection?
Well, as I just said, we found another 6 cancers, so that was average cancer detection rate of 10 per 1,000. And the cancers were small and node negative, so that's all very good. There were 2 cases of DCIS that we saw only on the pre-contrast images, the low energy images, well, not pre-contrast, but the low energy images based on calcifications. And so it is, not every cancer will enhance. We also had 2 lesions, one that was only 2 millimeter DCIS that was seen only on MRI, and one that was a 2 millimeter invasive lobular cancer next door to a known invasive lobular cancer, also not seen until surgery. So it's not a perfect test, but it does find cancers very small. We're actually about to start on a study looking at every other year supplemental screening with contrast mammography because these cancers are so small when we're finding them that we think that may be sufficient in women who are having annual tomosynthesis. What we don't know is whether they actually need the tomosynthesis. We're doing reader studies now to look at that as well because we did not find any cancers that were seen only on tomosynthesis. It certainly helps our confidence. We see, we're familiar with the tomosynthesis. We can sometimes in retrospect see an area of distortion that corresponds to the area of enhancement, and then we're very sure of what's going on. And sometimes it can help reduce false positives, I think, but that's part of a reader study that we're going to be doing.
Excellent, thank you. What should radiologists talk with their patients about before offering contrast-enhanced mammography with DBT?
So I think the most important thing to discuss, and I've actually done a lot of the recruiting for my studies over the years, is the experience of the contrast. It does require starting an IV, typically in the hand or elbow, and then we inject contrast, which is the same contrast used for CT scanning, iodinated contrast. It makes you feel warm all over, first metallic taste in the mouth, then you feel it down your chest, then you feel like you're going to pee yourself, and then it goes to your toes, and then it goes away. But it's not a very comfortable experience, and I'm actually in my own studies, so I can speak from experience. But it does go away quickly, and the staff, of course, all have to be trained in contrast reactions, but the patient also needs to be aware that there's about a 1% chance of having some kind of an allergic reaction. Hives is the most common. It's usually easily treated with Benadryl by mouth, but women need to be aware of those risks and accept those issues, and the staff have to be well trained. Our biggest issue in implementation has actually been that we thought the technologists would be happy to start IVs and do the injections like they do in CT and MRI, but that was a big barrier for for technologists who perform mammograms to start doing something like that. So we've actually had our nurses do the IVs in our practice, and that has worked out better. It's been a cultural shift in the practice over time, but actually our technologists do the bulk of the recruiting to our studies, so they are very interested in the results. We have monthly conferences to go over cases to help educate the technologists and the doctors about what we're learning and seeing, because it is quite subtle. I think one of the things that we've been surprised by is how often the cancer can be very hard to see, even on the contrast mammogram, or only on one view, even though it's should be in both pictures. And that's something that also represents a learning curve and is interesting. And then I think the final thing is just if a biopsy is needed, and more women will need a biopsy, so women, when we're talking to patients, need to be aware of the risk of additional testing, and that is billed to insurance even when it's done in a research study. That we found 9% of the women in this study had to have a biopsy because of the CEM, and only, I think it was 16% of those showed cancer, so it's not a very high percentage. And that's something to be aware of as well. So it's a downside. Those results were actually better in the women with personal history of breast cancer. There were fewer false positives and also more likely to be cancer. So it may be an especially good test in women who've had a personal history of breast cancer.
I was just about to go off script and ask you that very question about about the false positive rate, but you covered it. Well, thank you for your time today. For more information about the study, look for this RSNA 2023 session on demand. And as always, you can find more radiology news at rsna.org/bulletin.